Good afternoon, everyone. I'm Nirav Shah, the director of the Maine CDC, and I am joined this afternoon by Commissioner Gene Wamber from Maine's Department of Health and Human Services. Commissioner Wamber and I are pleased to be with everyone today to talk about where we stand with respect to COVID-19 for today, Wednesday, January 26th, 2022. We begin today's update on yet another sad and somber note. The Maine CDC is reporting 2 additional COVID-19 related deaths today. One was a resident of Cumberland County, and the other a resident of York County. One was a woman, the other was a man. One was in their 70s, and the other in their 80s. We'd like to offer our deepest condolences to the friends, family members, and communities of both of these individuals, as well as the 1,714 other individuals who have passed away with COVID-19 throughout the pandemic. Overall, statewide, the Maine CDC has recorded 169,998 cases. Right now in Maine, there are 408 people who are hospitalized with COVID-19. 2 weeks ago, that number was at 413. Right now in the state, there are 88 people who are in a critical care unit bed with COVID-19, whereas 2 weeks ago, that number stood at 106. We've seen a similar downturn in terms of the number of people who are on ventilators, where right now there are 38 people on a ventilator, down from 57 2 weeks ago. I'd like to pause on these numbers because with everything going on right now, there's a lot of uncertainty out there, particularly with Omicron spreading across the country. Things feel dark, they feel uncertain. And for so many of us, the pandemic seems like this Mobius strip of bad news. But there are signs of hope on the horizon. For example, with these hospitalization numbers. Now, those numbers are high, no doubt about it. We're still at a high point. But the 2-week comparison suggests that the trend is in our favor here. That number of those in the ICU, 88 people, is the second day in a row where we've been below 100 people in the ICU since December 1st of last year. We hope that these numbers continue. Now, turning next to testing. The 7-day PCR positivity rate in Maine now stands at 17.4%. There, too, there have been improvements. 2 weeks ago, the PCR positivity rate was 19.8%, not far from a high point of 21.5%. That was the high point throughout the pandemic that we reached on January 17th of this year. But today, we're at 17.4%. Our testing volume, too, remains high and robust at 763 per 100,000. As with hospitalizations, these metrics remain at a high point, but are starting to trend in a more favorable, more hopeful direction. Let's turn next to vaccines. Right now, Maine is administering just under 3,000 doses of COVID-19 vaccine every single day. That is still a high number of vaccinations, although it is down 35% just in the past week and about 47% over the past 2 weeks. But make no mistake, Maine has accomplished great things with respect to our vaccination efforts. As of this morning, 77.3% of every single person in Maine is fully vaccinated against COVID-19. And among those who are fully vaccinated, 51.4% are boosted. Those numbers put us in the number 3 spot in the country for the percent of our total population that is fully vaccinated, and they tie us for the number 1 spot in the country with other states in terms of the percentage of our state that is over 65 that are fully vaccinated. Let me say that again. Maine is tied for the number 1 spot in the country in terms of the percentage of our state that is over the age of 65 who are fully vaccinated. I've got a number of updates that I wanted to provide as it relates to all things COVID-19. Let's start with treatment. On Friday of last week, the U.S. Food and Drug Administration, the U.S. FDA, issued a full approval for the use of a drug called remdesivir to treat patients in an outpatient manner to prevent them from ending up in the hospital. This full FDA approval is a big step forward. It means that a drug that is 87% effective at preventing hospitalizations, a drug that is plentiful in supply, a drug that is safe, and a drug that is active against the Omicron variant can now be more widely used to prevent patients from ending up in the hospital. It's a treatment that hospitals have been using since earlier in the pandemic, meaning that clinicians are already familiar with it. This is a big step forward for our state, for our country. Maine CDC issued an advisory to clinicians on Monday to alert them of this full US FDA approval, to provide them with the scientific data that the FDA used to support that full approval, as well as instructions on how to administer the drug. My second update is around vaccines and vaccine availability. As I mentioned last week, the Augusta Armory's last full clinic will be tomorrow on Thursday. Now, to rewind the clock a little bit, we opened the Augusta Armory on December 7th in direct response to an urgent need for vaccines, namely boosters. I'm pleased to report today that we met that call and we met that mission. The team to date has vaccinated more than 10,700 people of all ages at the Augusta Armory. That site was made possible because of our team as well as the broader community. It was a joint effort across the Maine DHHS, Maine CDC, the Maine Emergency Management Agency, and the Maine National Guard, as well as, I want to make sure everyone is aware of this, dozens of volunteers across Maine who braved the cold, who worked through the holidays, who worked on evenings and weekends to vaccinate their fellow Mainers. I'm so proud of the effort that all of us came together in order to meet the moment and meet the demand for vaccines. Now, testing will continue at the Augusta Armory 3 days per week. While an appointment is recommended, an appointment for testing at the Augusta Armory is no longer required. We'd prefer that you book an appointment, but one is not necessarily required based on availability and how busy the site is at that time. The Augusta Armory testing site is open Monday, Wednesday, and Friday from 9 a.m. until 3 p.m. They offer saliva-based PCR testing free of charge with results that are mailed to you usually that night. Now, we know that there remains a need for testing right now, and that's why Commissioner Lambrou and I are pleased to announce 3 additional testing sites today. The first one is in Windham. Maine DHHS, Maine CDC, in partnership with Windham Fire and Rescue, Mercy Hospital, and our federal colleagues at FEMA, have opened a testing site in Windham at the Windham Mall. That site is open Monday through Friday from 8 a.m. until 4 p.m. and is live right now. Testing is free, but an appointment is required. To register, I urge everyone to check out our website and or our social media pages to find the registration link. The second new testing site is one that opens tomorrow in Biddeford. It will be located at the Biddeford Shopping Center on Alfred Street. And starting tomorrow, it will be open Monday through Friday from 10 a.m. until 4 p.m. Similarly, testing is free, but an appointment is required. There too, please check out our website and our social media pages for more information on how to register. That is being launched in partnership by the Maine CDC, the York County Emergency Management Agency, and the Biddeford Emergency Management Agency. And third, beginning on Monday, January 31st, rapid antigen testing will be available at the YMCA in Auburn. The hours there will be Monday through Thursday from 10 a.m. until 2 p.m. Appointments are available and recommended and preferred, but not required. This site is a collaboration among a broad number of community partners, including the New Mainers Public Health Initiative, AK Health and Social Services, Multicultural Community and Family Support Services, Maine Community Integration, Gateway Community Services, and the Maine Immigrant Refugee Services. We know that testing has been a challenge, and we hope that these additional 3 sites will help folks find a test when they need it. The next set of updates today is around wastewater. Last week, I talked about what wastewater screening is, why Maine was using it, and what it tells us. I'd like to provide updates today on how we are moving ahead with expanded wastewater screening in Maine. There are 2 approaches, 2 parallel tracks toward this expanded offering and use of wastewater screening in Maine. One is through a broader effort from the US CDC. There are 7 sites that are 7 municipalities that are part of that process. Sampling has already begun at 2 of those 7 sites in Rockland and Booth Bay, with 5 additional municipalities joining and starting their screening process in the coming days. Those additional 5 sites are in Bethel, Wilton, Bath, Yarmouth, and in the Guilford-Sangerville area. In parallel is a Maine CDC-driven effort with up to and eventually 16 additional municipalities on top of the 7 that I just mentioned. Right now, we've enlisted the partnership of 8 municipalities and their water districts. In Blue Hill, Belfast, the Augusta Utility District, Calais, the Brunswick Sewer District, the Presque Isle Water District, and 2 districts in Portland, East End and Westbrook. All told, there will be at least 20 and approximately 23 municipalities, if not more, that will be participating in this broad wastewater screening effort. And finally, I'd like to provide an update today on where we stand with respect to processing the backlog of positive laboratory tests that are awaiting review. As of this morning, there are 56,000 positive laboratory results in the queue awaiting review by Maine CDC epidemiologists. That number is high, and Maine CDC is committed to addressing it. A few reminders at the top. This is not a testing backlog. Our state laboratory is turning around labs in 24 hours, despite receiving a high record number of samples. And for example, those who are visiting our testing site in Augusta are getting their test results back overnight, as I mentioned a moment ago. I'd also like to remind folks of what does not change as a result of this backlog. And that is, importantly, people getting notified of their positive test result. If you test positive for COVID-19, you get notified perhaps by the clinician who ordered the test, probably, almost certainly by the lab that ran the test, as well as through an automated process at the Maine CDC. The bottom line is if you test positive, you'll find out, regardless of what the backlog stands at. The backlog has no impact on when you find out or what you should do, which is to isolate. So what is the backlog? Well, it's a queue of positive test results that are reported to us that we have to process. Why do we have this? Well, the first thing is Maine is not alone. Other states do as well. But specifically in Maine, we have a backlog in part because we chose to remain committed to the process of case investigation. Case investigation is where a Maine CDC epidemiologist contacts individuals who have tested positive with COVID to learn where they may have been exposed. Case investigation provides important information that has informed our approach and information that we have been able to share about who's getting COVID, where, and with what symptoms. Now, this same information is shared among epidemiologists within the Maine CDC in real time with an important goal: to spot outbreaks. You see, it's hard to know whether the pieces of an outbreak are part of an actual puzzle unless we conduct the case investigations to put those puzzle pieces together ourselves. What's an example of that? Well, the August 2020 outbreak investigation associated with a wedding in East Millinocket was a prime example of how and when and where case investigation led to spotting an outbreak. We know about outbreaks early on because we connect the dots, and those dots are the result of case investigation. But Omicron has changed things. It's more contagious, it spreads earlier, and it spreads in a shorter time period shortly after someone is exposed. And as a result, we too must transition away from the human-driven case investigation model toward an automated one. That is what our team is focused on right now. And that is ultimately what will help us reduce this backlog. But it's important to note, and something that we've talked about during these meetings, that this change away from case investigation is part of a broader context about the metrics that matter at this point in the pandemic. As we talked about last week, Omicron has lessened the utility of things like daily case counts, while it has simultaneously upped the importance of other metrics like hospitalizations and, as I've talked about more recently, wastewater screening. So with that, we're going to turn things over to our colleagues in the media. The first question today goes to Brian Sullivan.
Thank you, Dr. Shah. I just have a couple of maybe clarifiers about the backlog and how long, so 56,000 cases with the backlog, how long could a case sit there before it becomes null and void, I guess? How far are these cases dating back? And at some point, does it, I guess, not matter whether it's carried out to fruition?
No, it's a good question, Brian. It does matter because we want to capture the data in those cases. We still want to know who's been affected, where they live, where they've been, things of that nature. Now, we're going to be automating much of that process, so it won't be done by a human. Indeed, throughout the pandemic, as case counts have gone up, we've had to be more selective with who we investigated versus who we didn't. But it still matters. Having those data, first of all, is a requirement from the US CDC. So it's not as if we can just take all the cases in the backlog and just add them to the number on our website and call it a day. The US CDC wants to know who those folks are and what we know about them. So it still does matter.
And I have a question about wastewater as well, but just getting through that 56,000 as you do go through that process of automating it, what's that look like? How long do you foresee that taking?
It's a priority for our epidemiology team right now. I've been working with them to make sure that they have the time to focus on this, to make sure that project comes online. It's a technical project, I will tell you. It requires building an AI, an artificial system, or an AI system that does what individuals would have done, but abstracts much of this data automated in an automated fashion rather than having to have a human do it and spot these trends on their own. It's a lift. Other states have done so, but we're able to learn from them. We're at the point now, because of Omicron, where we're doing what other states have started to do, or have already done, which is move away from the human-based approach and more toward the automated one. I wanted to explain today why that human-centered approach has been so valuable to us until this point in the pandemic. It still remains. Even with the fully automated approach, we're not abandoning case investigation altogether. It will be just done in a different manner. It's going to take time. I'm committed to making sure the team that's working on it has the space and the bandwidth to focus on it.
Okay. When it comes to wastewater, maybe this is a question for next week or something, but when, a lot of people spend a lot of time on your website going through information, can you explain to me, a layman, when that data does come out, what I'm looking for and how I understand what I'm seeing when those municipalities do report the numbers?
Yeah, Brian, that's a great question. Let's start with the data themselves, because we intend to make all of this data fully publicly available. As you know, it's going to take us time to get the visualizations up, to get them the way that they should be, to make the data usable, digestible, understandable. So we're working on that. We anticipate having some of the first results. We've already, been working with municipalities to get those data, but we're working to have some of the early results up, maybe sometime late next week. That's a maybe. But to answer your question more directly, Brian, wastewater testing and the data that we generate from it are useful because of how it may change. It's less useful on a day-to-day basis, but more useful on a week-to-week basis to compare where we were last week against where we were this week. In order for this to have utility, you first have to establish a baseline. So the first several weeks of wastewater surveillance screening data will be used to establish a baseline. We're going to be public with that, but having established a baseline, because it might be different in one community versus another community, the thing to look for then is the trend. Is the trend going upward? Is it going downward? The second thing to look for is very significant concentrated spikes. Those are the things that we're going to be looking at when we are scanning the data to see if we need to alert hospitals and providers in the area that someone who comes in with symptoms of COVID may have a higher than likelihood chance of getting COVID. So that's how we're going to be approaching our analysis of the data, Brian, is to look for the trends.
Okay, thank you.
Mm-hmm. Yep. Let me go to Chris Costa next.
Hi, Dr. Shah and Commissioner Landrieu. Thanks for taking the time today. I really appreciate it. I wanted to start with asking you about about breakthrough cases, and specifically how that relates to people who have had a final dose of an mRNA, that second dose, or the one shot of J&J, and then compared to people who have had a booster shot. Northern Light Health discussed this earlier today and showed some data from the White House. It showed that people who had had a second shot of an mRNA, like a Pfizer or Moderna, if it had been more than 6 months since that final dose, that the effectiveness of the vaccine started to diminish significantly against the Omicron variant. But that once they got a booster, the effectiveness raised back up to about 90% in terms of preventing, I believe it was hospitalization. Can you explain why that is? And if you're seeing the hospitalizations of people now, are these people who have not gotten their booster? The people who are vaccinated but still ending up in the hospital, the breakthrough cases?
Great question, Chris. And you've captured the data accurately. Let me start by noting that the vaccinations and vaccines are still remarkably effective. And Chris, I know you did not mean to suggest that they're not, but
oh no, I'm sorry. Yeah, I didn't mean.
No, I totally get that. But for those who are watching and listening, the vaccines still remain remarkably effective. The question on the table is, how can we sustain that maximum protection from the vaccine? That's fundamentally the question that Chris is raising, especially as time goes on. After you've completed your dose, how do you get back a sustained, robust level of protection that you may have enjoyed 2 weeks after your second dose? The answer is via a booster. Why is that? One of the things that we've learned about the Omicron variant is that it changes and can evade. It's a little slippery with respect to how it interacts with the body's immune system. That's for two reasons. The first is that it has a number of mutations that make it appear to the body to be just a little bit different than the Delta variant. The other reason is that, as with any vaccine, our body's immune system response fades just a little bit over time. And that doesn't matter if it's the measles vaccine, the tetanus shot, or in this case with COVID. When you combine Omicron being a bit slipperier, plus our body's own natural fading away of the immune system, you get a reduction in the effectiveness of the vaccine that is significant enough to warrant having a booster. And that's why you saw in the fall and more recently, the US CDC, the US FDA, and the Maine CDC really recommending that folks get boosters. What we've really learned about these vaccines, Chris, is that they work the best when you get all 3 doses. And that's because of the natural changes in our body, as well as the differences with the Omicron variant.
Okay, thank you for explaining that. I know it was kind of dense. The second question I had for you was about kids under the age of 5. I know we've talked about this several times now, but I just keep looking back at the data that the Maine CDC and DHHS are publishing about this. I know in the month of December of 21, there were more than 1,400 kids under the age of 5. And the reason I bring up that age group is because they're too young to get a vaccine right now. 1,400 kids under the age of 5 that were cases, just simply cases, not talking about severity, they just tested positive. So far through January, the data that the CDC has released so far says we have more than 1,200 kids. And that data is only really through halfway through the month. So I guess my question is, 1, should we be concerned about the spread of the virus in this young group? And 2, what is the severity of the illness in these kids? There are some numbers in that youth report that I think might be a little bit, I think they're accurate. I just think they might be a little bit confusing in trying to explain how severe the illness is, if that makes any sense.
It does, Chris, and I'm glad it's a good point to raise. One of an early notion in the pandemic was, and you'll recall this, there was an early notion that kids don't get affected by COVID. And there were all these theories about why, and that may have been true early on in the pandemic, but with the Omicron variant, that's changed. And the data that you noted, Chris, are proof positive of that. Kids have been affected by the Omicron variant, infected by it, and indeed, they are part of the reason why across the country and in Maine, case counts have gone up. But the question you ask, Chris, is, should we be worried about this? And of course, we should be concerned anytime a child is getting sick. There's no question about that. Kids aren't supposed to get sick. They're not supposed to have severe outcomes. But we also need to think through what the implications of them getting sick are. When they do get sick, which is always unfortunate, what is the magnitude and the severity? Now, I want to say this, but I want to state at the outset that no one is downplaying the risk or the impact of a child having COVID. But thankfully, one finding that has held true is that children are not as severely affected as are adults with COVID. However, with the Omicron variant and how fast it spreads and how quickly it goes through a community, something that happens rarely, like a child being hospitalized, can cause more raw numbers of hospitalizations just because of how many kids are being affected. And that's why nationwide, a few days ago, the US CDC put out data indicating that hospitalizations are up across the country among kids because of the Omicron variant. We've seen a small amount of that trend here in Maine. But the severity of their illness, thankfully, has not been on a per case basis necessarily worse than that of adults. That's a lot of talk back and forth. Here's the bottom line with all of that. Kids can get COVID, they can get Omicron, and because of how contagious it is a risk. However, thankfully, when they do get Omicron, they do not routinely suffer the same significant clinical consequences as do adults.
Thank you for explaining that. My last question is super, super quick. Omicron has obviously changed a lot of things that we know about COVID-19 and kind of the trajectory we had seen with the severity of the illness as it progressed into like the Delta variant. Is there any emerging or new misinformation or intentional disinformation that either the Maine CDC or DHHS is hearing or seeing surrounding the Omicron variant and COVID?
Commissioner, if you've got there's almost so many to choose from. Commissioner, if you have one off the top of your head.
Yeah, we've heard that people think just get it. Go out there, don't mask, don't worry about it because it's not as severe. When, as a reminder, it can be severe for people who are not up to date on their vaccines. We should remember that there is this new dynamic that's emerging, which is for those people who are up to date on their vaccination, meaning they've had their series and if eligible, they've had a booster, they may not get very sick from Omicron, but we can still see people who can catch this strain of the virus and become very ill. So that's one I hope that people understand. It really does matter to get boosted if you're fully vaccinated, to get fully vaccinated if you're not, because it is two different outcomes from the same variant.
Thank you both for your time and patience.
Chris, I would build on that. I would build on what the commissioner noted. I don't think I'm going to, this is not labeled as misinformation, but just a misperception because of how quickly moving and how tough this stuff is. What I was going to point to, and it builds on what the commissioner noted, is the notion that Omicron is mild. And I think, Chris, the way that I would frame it is milder, but not mild. Omicron is still a significant illness. It's milder. It can be milder than it was, say, if you had Delta, but it's still a significant illness. That's not necessarily misinformation. It's just, again, a reminder of how tough this stuff is to ferret out. But if I had to summarize it, Omicron is milder, but not mild.
Okay. Thanks for the patience. I appreciate it.
Yep. Thanks, Chris. Let me go to Patty White next.
Thanks, Dr. Shah and Commissioner Lambrou. The wastewater testing sites that are participating in the U.S. CDC screening program are all in the lower half of the state. Can you tell us why there aren't more further north and east in that particular program?
Yeah, Patty, our team raised this with the U.S. CDC, and this was the methodology that they developed and that they largely chose and utilized in selection of sites. Our team pushed back on, or I should say, asked significant questions of that methodology, given what it resulted in Maine. That is, in fact, Patty, one of the reasons why we launched our own parallel track. That's the behind the scenes as to why there are two tracks. For the reason, in part, because we're a large state, we wanted to cast a broader geography, but also because of the equity reason that you noted. I hate to say I refer you to the U.S. CDC, but it is their methodology. Those site selection was something that they did, but as we saw what that looked like from a geographic and equity perspective, that's one reason we pursued a parallel track.
Okay, thanks. And in terms of remdesivir, from what I understand, that may or may not be covered by insurance, so that could be a barrier for some patients. Is the state planning to take any sort of action to ensure, anyone who's eligible can get that, whether, regardless of insurance status?
I know it's something that Commissioner Lambrou and I have discussed. Commissioner, I'll turn that over to you.
Yep, we are looking into our different policies to see what, if anything, we might do at the state level. Note that Medicare and Medicaid policy tend to be set at the federal level. So we're exploring both what the state of Maine might be able to do in this regard to make this particular medication affordable to people, as well as what could the federal government do to see if that is a possibility. Thank you.
Okay, thanks.
Thanks, Patty. And yep, thank you. Let me go to Patrick Whittle next.
Well, thank you very much. Just want to make sure I understand a few things about the backlog. The backlog is of positive cases that need to be confirmed, correct?
First part's correct. They are a backlog of positive cases. They have been confirmed. These are individuals whose test results are positive. They have been reported to us electronically by the laboratory that did that lab test, whether it was Quest or LabCorp or whomever. What we have to do is take that result and make sure we have all the information around it that the US CDC requires states to have before we turn it into a case.
Oh, okay, I see. And that stands at 56,000, is that right?
That's correct. That's correct. But Patrick, implicit in your question, I just want to make sure these are not laboratories that are sitting on specimens. These are numbers that are on a server at the Maine CDC of folks who have already been notified of their result, who should already be appropriately isolating and taking the necessary public health steps. The folks who sought testing are already aware of this. We just have to do the back end process of converting a positive lab result into a case.
Right. And this backlog exists in part because officials have stayed committed to the process of case investigation.
That's right. Case investigation is intrinsically a human-to-human process, and we've scaled it up and down based on the demands of the virus at different times. But we found value in that because it helped us understand what was going on, and the data that we've talked about at these very briefings. When folks ask how many folks in this part of the state are experiencing this, or what is the exposure what is the nature of exposures from these settings versus other settings? We know that stuff in Maine because of the importance of case investigation. We're now, as our other, we are now moving in the direction that numerous other states have already moved, which is toward automating that process.
Right. And so, how does this relate to the fact that the spread of the Omicron variant has made it so daily case counts don't have as much value as they used to? What is the synergy there?
Yeah, that's a good question. I'm glad you spotlight that. It's in short, Patrick, for two reasons. The first is that Omicron is everywhere. Right? It used to be that COVID was something that was discrete, that when we intervened quickly, we could limit the onward transmission of. But Omicron, because it's so much more contagious and it spreads pretty soon after somebody is exposed, and it does most of that spreading in the first few days, the utility of, first of all, just having a daily case count is called into question because it's everywhere, but also the process of getting that lab result, calling folks, asking them where they've been, all of that back end process, it's still useful, but less so than it was back in April of 2020, because the background rates are just so high everywhere.
So is it possible that it's going to be more difficult to manage the case counts with new testing locations opening up and also with starting these wastewater samples? Because it seems like you might be getting more data than less.
Well, on the wastewater screening piece, Patrick, that's a separate process altogether. But as to the former question, I don't know the answer, but I am certainly not going to stand in the way of expanding testing. Getting more people testing in the midst of a surge is what really matters. And whatever that means for the backlog is what it means for the backlog. What matters is getting people access to testing and getting them their results. The backlog is not affected by any of that. I mean, really, truly, the backlog is something that happens on computers at Maine CDC. It doesn't affect what's going on for individuals out there insofar as that what it really drives is the daily case count. That's what the backlog really is a function of. It's the driver of that daily case count. And again, because of these different scientific features of Omicron, the daily case count is not really the metric of this moment. It's really more things like hospitalizations, things like that.
And when we talk about automation, can you give us an idea of what that looks like? What does automation mean in this context?
Yep. It entails designing and programming a bot that takes all of the disparate pieces of information and stitches them together. It takes a positive lab result and then queries other databases for that person's name to make sure that it's not a duplicate result for someone who got tested more than once within 90 days. It then also queries other systems that we have to find out where that person, what their zip code is, so we can put them on the zip code map, so on and so forth. It stitches all of that information together, the bot does, and then packages it and uploads it to the US CDC. Right now, that process is one that occurs by individuals because we want to be talking with folks. But as we automate it, that's what will essentially happen. The bot will do not all of that, but the bulk of it.
Okay, great. Thank you very much for clarifying all of this.
Yep. Thank you, Patrick. Let me go to Talia Clark next.
Hello, Dr. Shah. I know in the very beginning you were highlighting some of the positives of booster shot rate in our state in comparison to the rest of the country, but have you noticed that the booster vaccination rate is stalling, stuck at a little over 50% of Mainers who got their initial shots and then got boosted?
I wouldn't characterize it as stalling, Talia. What we've seen throughout vaccination efforts over the past 13 months. It's crazy to think we've been doing this for 13 months. But what we've seen is that after a new group becomes eligible, there is a significant surge in demand. And that's what was happening around the time of the end of November, early December. New groups and new recommendations had just come out for everybody to get a booster, if you'll recall. And that generated, reasonably so, a surge in demand. We found that there weren't sufficient other sites to meet that demand, and that's why we stood up the testing, the vaccination site. But the history of vaccination in Maine and elsewhere has been kind of a series of big steps. The first big step happens in the first few weeks after a new requirement or a new recommendation is made, but then naturally it tapers off. To put it differently, the second half of any type of exercise is always harder than the first half. And the last couple miles are always the hardest part. I wouldn't characterize this as stalling. It's what we expected would happen as we launched these sites.
Thank you, Doctor.
Let me go to Caitlin Andrews next.
Good afternoon, Dr. Shah, Commissioner Lambrou. Two questions. One is the city of Bangor is preparing to resume its COVID wastewater testing program. It had halted earlier in the pandemic. Given that such testing includes samples from a general population rather than people getting tested, do you feel this testing method would be the most effective way for communities to measure infection rates during this current wave going forward?
Caitlin, could you just repeat the middle part of your question? I heard you say that Bangor is resuming wastewater testing, but you dropped just a bit in the middle.
Let me try again. So given that such testing includes samples from a general population rather than people getting tested, you feel that this testing method could be the most effective way for communities to measure infection rates during this current wave and beyond?
I do, Caitlin, and not just me. Forget about what I think, but the US CDC has also endorsed this method to get a scan of what's happening at the population level. Indeed, what you framed as a potential downside is actually an upside when it comes to wastewater testing or wastewater screening. Right now, our view of what's happening with respect to COVID-19 is driven by who opts to get tested. And in an era of a lot of people having a breakthrough case that might be mild, or the Omicron being milder but still not mild, or a lot of folks having difficulty accessing testing, we may in fact have a skewed view of the pandemic right now. Now, that's the case with every single outbreak that's ever been known. There's always a sense that you're not seeing the entire thing. But wastewater in that respect is the equalizer. Because it samples from the entire population, those who are vaccinated and unvaccinated, those who are symptomatic and non-symptomatic, those who decide to get tested, those who don't get tested. In that sense, it is a true population health metric. It's designed and it does answer the question that we should all be caring about, which is what's going on in my community and how is that changing and what does that mean going forward? So I far from seeing it as a downside, it is in fact a principal strength.
Thank you. My second question is, given the impact case numbers continue to have on federal COVID policy, should we have reduced our test processing capabilities last year, and should we keep it at a sustained level going forward?
Caitlin, I'm sorry, I did not hear your question. Can you give it another shot? If not, email it to Robert and we'll get you an answer, but give it another shot, please.
All right, can you hear me now?
Not that well.
Oh, terrible State House acoustics here.
No, we can hear you okay right now, Caitlin. Go ahead.
Okay. So given the impact that case numbers continue to have on federal COVID policy, should we have reduced our test processing capabilities last year, and should we sustain it going forward?
We have not reduced our test processing capabilities. We've made sure that we can continue to offer tests and make sure that we can make sure that those results are processed. What we're dealing with now is something that's a function of the Omicron variant, something that a number of states have been contending with, as I talked with a number of states in the US CDC about this exact issue last night. But the Omicron variant has really been what's changed everything recently.
And I will just add that we appreciate the fact that in presenting the information on Omicron and data issues with Omicron to our federal partners, they did adjust Maine's allocation. So we feel as though our federal partners are listening. The pandemic has evolved, and we're hoping that they modify their allocation formula to be aligned with other therapeutics going forward.
Thanks, Caitlin. And the last question for the afternoon goes to Joe Lawler.
Hello. Yes, thanks for taking our questions. Just a quick timing question here. The automated process, do you have a sense of when that will happen? Are we talking like a couple weeks from now or a month or two? Do we know how long it will take?
Joe, let me say two things. The first is we are committed toward working on that project. I've made it a top priority of our epidemiology team. I've tried to clear the decks for them so that they can focus on it. It is a highly, highly technical project. It's one that other states who moved away from case investigation much, much earlier in the pandemic spent significant amounts of time on. We're able to learn from them because they moved away from case investigation sooner and moved toward automation a lot earlier. We can learn from them, but it is still a very significant project. I hesitate to provide even a timeline, but I will tell you that we're committed to it, and I've cleared the time for the team to focus on it. But I don't want to discount how technical and difficult it is.
And is that part of the reason why you're deciding in late January to move to automation versus, say, making this decision in, let's say, late December or early January?
Yeah, I mean, in terms of the timing, Joe, the Omicron variant is really what is driving this. We started having these discussions in earnest as we started seeing case numbers spike in late December or early January here, and building upon the experience and seeing the experience that South Africa and the UK had. We had a good sense of the spike that was coming here, and that's when we started working with the team toward that. I think to do so earlier would have, I don't want to say it would have. I guess what I want to say, Joe, is that case investigation is something that we have been committed to, and to move away from it sooner would have meant something. And we are only doing so now because Omicron is of a sort that automation is really the answer.
Okay. Just a little bit more on this. I know it's been, this session has taken a while, but just bear with me a little bit more. So do we know when it does go to automation, will it be reflected historically, or will we get like 20,000 cases dumped on one day, for instance? I'm just wondering if there will be a time we'll be able to retrospectively look back and be able to, through case count, see the curve up and the curve down.
Both, Joe. So we already do that. On our website, we and best practice in epidemiology is to track cases in two manners. One manner is the day on which they were a case. That is a function of processing. The other is the epidemiological approach that says we should also track them based on the progression of the disease. When people started feeling symptoms, for example, and we already do that. We track both because that's epidemiological best practice. We'll continue to do that when it comes to automation if those data are available. But to your former question, Joe, I don't want to predict too far into the future, but our plan will be if and when this automation bot or that entire series of neural nets and AIs and all of those things are ready to go, we are hoping to dedicate a bunch of computing power to it so that we can clear out in rapid time. And there thus may be a significant spike. That is a ways away, and we will absolutely let people know that that process is going to be running so that all of a sudden folks don't wake up and there's 5-digit more cases on the case count. But it's going to take time. We want to test it. We want to get it right before we just go out with it.
Okay, my last question is to Commissioner Lambrou on the formula that you referenced for monoclonal antibodies, and considering that it's going to take a while before the automation occurs. Did you get any sense from the Biden administration that our antibody supplies will still be robust and that it won't go back to the old way and then we get shortchanged?
Yep. So we believe that we will be getting more than we have been getting based on the pure metric of 7-day new case counts. So we thank the Biden administration for that. We do refer you to the U.S. Department of Health and Human Services for those specifics, but I would just like to thank them. Not only have they listened and are trying to figure out with Maine and other states, because we're not the only state with this concern, how they adjust this going forward. The U.S. Department of Health and Human Services is also supporting the wastewater testing program through the Maine CDC, is supporting that Wyndham site through the Assistant Secretary of Health, and it continues to work with us on the therapeutic allocation. I will also note that we are beginning to hear that the free over-the-counter tests that they made available through covidtest.gov are beginning to arrive, hopefully in Maine soon. And we are hopeful that by the end of this week, we can announce our own free over-the-counter test program. So we do continue to work with our federal partners on supplies coming to Maine, as well as working on our own efforts to make testing and therapeutics more available.
Thank you.
Very good. Thanks, Joe. And that takes us to the end of our questions for the afternoon. Commissioner, any parting thoughts from you this afternoon?
Just a reminder that we always encourage people to get tested, putting aside the data and the trends, which do matter. It matters to you. Finding out if you're COVID positive gives you the tool to figure out what to do, to isolate, to be in contact with your doctor, to let your friends and family know that they may be close contacts. So we're excited about the 3 new testing sites that are opening, as well as the expanding access to over-the-counter tests. If you need to find a test, you can always go to our website to find out your testing options, which is maine.gov/COVID-19/testing.
Very good. Well, thank you all for your time today. Thanks for joining us and spending some of your afternoon hearing about where we stand in Maine. We look forward to chatting with everyone again soon. In the meantime, as always, please be kind and take care of one another. We'll see everyone later.